السلام عليكم ورحمة الله تعالى وبركاته. أسعد الله مساء الجميع بكل خير. Today, first of all, we are very sorry for the delay. We have a technical issue with the connection with the internet, but luckily at the end we managed to do it. Today, our presenter is Dr. Ahmed Al-Na'mi. He is a pioneer and senior interventional radiologist in the kingdom. He is one of the people who make the program in Saudi Arabia of radiology, as well as interventional radiology. Currently, Dr. Ahmed Al-Na'mi, he is working as a head of interventional radiology in Al Muassa Hospital. Dr. Ahmed Al-Na'mi, he did his training, fellowship training in Toronto, Canada. He has 2 fellowship as a body imaging consultant, as well as vascular and non-vascular interventional radiology since 2000. Dr. Ahmed Al-Na'mi going to present today a lecture about radiofrequency ablation of thyroid benign nodule. Dr. Ahmed Al-Na'mi, the stage is yours, please.
بسم الله الرحمن الرحيم. لله رب العالمين والصلاة والسلام. أولا قبل كل شيء كل عام وأنتم بخير. Thank you, Mr. Chairman, Dr. Abdullah. Thank you to all the people who are behind this successful radiology club, and thank you to the sirs and to all the teams. وكل عام وأنتم بخير. Ablation of thyroid benign nodules is one of the so if we start just talking about the thyroid gland as an anatomy, a gland which makes stores of hormones that help to regulate the heart rate and blood pressure, and it has a lot of functionality on the body itself and the metabolism. And if we look at it, it's situated anterior in the neck and anterior to the trachea, and it has, if we look at it in the ultrasound images, it has 2 lobes connected by isthmus. Behind is the trachea, and then the vascular structure supplying brain and draining the carotid and the internal jugular vein. So thyroid tumor in general, benign nodules count for about 90 to 95%. Thyroid cyst, thyroid nodule with fluid and fluid filled with cavity, also what's called goiter or thyromegaly, which is over 90% of goiter caused by iodine insufficiency. And also the thyroid cancer as a malignant thyroid tumor and AFTN or hot nodules. So if we look at the evidence and how, if we palpate patients, most of the time is about 4 to 8% that will be palpable, because sometimes they are small nodules that cannot be felt. But ultrasonographically, they can detect up to less than or equal 35%. And in pathological examination and autopsy, and in about 50%. So what are the indications for treatment? We'll be talking about the indication, the inclusion criteria, and as we go on. So cosmetic reason and also subjective symptoms for pressure symptoms. For example, breathing, swallowing, and voice changes. We'll go a little bit in detail as we go on. Anxiety about the malignant changes as well. So if we look at, in general, the treatment options, for a long time and decades, surgical resection or thyroidectomy was the trend, used mainly for malignant tumors, remove part or all of the thyroid gland, either 1 or 2, causes scarring and requires the administration of thyroid hormones indefinitely, which is for life. The radioactive iodine used for malignant tumor, this may cause hypothyroidism, and radiofrequency ablation now is used for benign nodule, whether it is cystic or non-cystic or AFTN recurrent thyroid cancer. In some cases, we have been using ethanol as an ablation, mostly when it's cystic or benign cystic nodule, but it requires sometimes a repeated application. Percutaneous laser ablation, similar, but it has a less success rate, and microwave in the horizon. If we look at surgery that they require to do a surgical incision, recovery will take a little bit of time, and the scarring as well. But it's definitely one of the procedures that requires in some of our patients for thyroid, either malignant or people who has a preference surgery rather than to do radiofrequency ablation. So the complication from surgery is hypothyroidism in up to 50%, laryngeal nerve injury up to 8%, either unilateral or bilateral, and hemorrhage or hematoma less than or equal 1%, and hypothyroidism 10%, permanent in about less than or equal to 4%. And then they can get infection as abscesses, granuloma, and chyle leak. Now we will just talk about the our topics, which is the thyroid radiofrequency ablation, which is a new non-surgical, minimally invasive technique which has been used to treat benign and malignant tumors. The RFA is performed effectively and safely with ultrasound. I have not used CT scan for any of the cases, but I use CT scan to map some of the cases with the retrosternal or retroclavicle extension. RFA refers to an alternating electric current oscillating between 200 and 1200 kilohertz. The application of this power, we have been using radiofrequency ablation for quite a while, since 1997, and we have been using it in the liver, as well as in the lung, as well in the kidneys, and in the bone as well, and parathyroid. So it is power agitating tissue arm that creates frictional heat around the electrodes. So indication of thyroid RFA, as we said earlier, that has been to be proven, cystic and non-cystic, and goiter, those confirmed to be benign as well, and AFTN. Nodules that increase in size and are bigger than 2 centimeters. So the contraindication is intermediate nodule, including follicular neoplasm, and those are the one should go for surgery. So RFA is particularly useful in patients with internal bleeding and growing the masses, cosmetic problem, compression pain due to the tumor itself, apprehension due to presence of thyroid tumor, an AFTN, and inoperable thyroid cancer. So you need to treat some of them to reduce the size, and it's a palliative rather than curative. Recurrent thyroid cancer. The inclusion criteria, as we mentioned earlier, also pressure symptom due to, we need to do an FNA to approve that it's a benign thyroid nodule. So the compressive symptoms, which we mentioned, people who swallowing, or problem with breathing as well, and a neck discomfort or full body sensation, or also hoarseness of the voice or change of voice every once in a while. Cosmetic problem and hyperfunctioning nodule, which is hot nodule, anxiety about malignancy, and parathyroid adenoma. I want you to pay attention to this slide because it's a very important slide. And I think it's one of the most important slides to take with you, which is the inclusion criteria. Who are those patients that you need to go? I think it's very important to select your patient carefully. And who are the people who is going to be treated? Older than 18 years of age. I treated the youngest patient I treated was 19. And it could mainly solid, but sometimes if it's cystic as a portion of it, less than 20%, but it's always okay that you have to aspirate the cyst and then ablate it. Benign nodule, and it has to be confirmed by 2 consecutive FNA. The problem that if you are working in the private sectors, it's very difficult to convince sometimes most of the people from the insurance company to do a second FNA. The Bethesda system for reporting thyroid cytopathology, but I always go to our cytopathologist and review the slides, and we are 100% sure, even if we do it once. AFTN nodule, hot at scientist scan, and no FNA is needed. If the nodule volume, the minimum is 6 mil to 20 to 25, greater than 25 needs a session of 25 ml each for AFTN and a minimum volume, because the larger the volume that you require some time to have more than one. And the blood tests, I think you have to work with the team, and the most important team is the endocrinologist who always see your patients. And I actually appreciate and I thank the administration at Al Muassa Hospital because of furnishing all this for such a procedure, because we have the communication with the endocrinologist, with the ENT together, and as well as the people who are doing the speech or educational program. And the blood work and all the investigation are done before the patient comes in, and then no vocal cord impairment by fiber optic laryngoscope. Not all patient needs that, but also you have to assess with ultrasound. Nodule measurement, perpendicular 2 diameter in transverse ultrasound and 1 diameter in longitudinal. And it's very important to repeat the measurement by the operator. And I always do that while they are in the clinic. I do it also when I am before starting the procedure. CT scan only nodule greater than 5 centimeter to explore the mediastinal involvement. And if we look into this, FNA or needle aspiration is important, and it's done as an outpatient. It's very important that you bring your cytologist and smear your slides right in there, so you will have enough cellular for diagnosis before leaving the patient. Ultrasound to cross-check biopsy finding as well, and exclusion criteria for RFA, nodule less than 5 millimeter in size. And I usually don't treat the 1 millimeter, the 10 millimeter nodule unless it's, unless the patient is really worried and all that. But I usually don't do that if it's 10 millimeter unless I follow them in a low surveillance follow-up on 3 months, 6 months, and 1 year, and see how the progression of that. Malignancy on FNA, and deal with sonographic criteria for malignancy. And if we look at the criteria, that's very important for Bethesda category type 2 category. There are 5 categories, and the most important one that we always deal with is the benign one. And you always want them, you don't want them to put you here in 1 or put you on 3. So either put you in 2 or put it in 4. So this is the most important for the diagnosis and to complete the procedure. So by ultrasound, if you look at malignancy, they don't respect the neighborhood around them. If you look at them, they are speculated. They don't have very well, they are following the plans of a tissue, and they are taller in diameter than in transverse, with the marked hypoechogenicity and absence of halo sign. While this one, which is the benign nodule, which is very soft, compressible, and it has a halo sign, and also the transverse, the AP diameter is smaller than the transverse diameter. So if general, you could have a solid nodule and you have to assess it by Doppler as well, or you can have cystic and solid component. And those are all treated. I usually aspirate most of the time, even when I am doing the FNA, I always aspirate and then do the FNA afterward. Preparation, sound examination, even if it's done properly, you have to do it yourself also and assess all the structures, FNA twice, laboratory data, thyroid function test, coagulation profile, and CBC. So what what do you need for the procedure? So a generator, which is and a pump as well, and disposable electrode kits. And those are the disposable one, and tubing for coiling, as well as the natural electrodes. The natural electrodes, and the needle usually is 18 gauge, 19 gauge internally with cold electrode. And if we look at them very careful, so those are the needles that you are using, and the needles has 3 connections. So this is the generator, which is come with an electric current, and then you have 2 connections, which are the cooling currents. So you have the tubing from here. It has 2 parts, which comes out here, and 2 parts, they will go into the eyes as inflow and outflow, and this one will be connected to the generator. And those are the pads, which are very important to be placed on the femur, on the thigh, and they have to be apart from each other and not to be connected to each other, close to each other. Thyroid protocol, the blood test, as we said, sedation. Some of those patients require some sedation, so I usually use only fentanyl and sometimes midazolam. Local anesthesia is a mandatory, and you start with a local anesthesia, and then it's very important to anesthetize the thyroid capsule. Hydro dissection, it's not necessary, but if you do it with 5% dextrose. If the lesion is very close to the skin, or there is some vital organs that you need to displace them a little bit. And sometimes I use D5 cold dextrose if there is any problem with the nerve during our heat. The specialized RFA electrode is inserted under ultrasound guidance, and RFA nodule start and is monitored by ultrasound in real time. So the patient usually is positioned in a supine position. We have created a drape sheet, which is very nice, and it's available now in the market, which is specifically for thyroid. So supine position, complete sterile technique, local anesthetic, as you see the nodules, and you can, this is the trachea. So the best thing is to go trans-ethnic approach. Sometimes it's very difficult, but the most important, if you can do it, it's the easiest and the best to do trans-ethnic approach. Moving shooting technique is very important. So we start from the bottom, and we'll show it in a minute how it's done. The anatomy. The anatomy is really important to understand and to study the ultrasound very carefully and to assess it. I think sometimes it's very difficult to know the track of some of the nerves, but at least you have to see the main ones that is very important. So if we look at here, the recurrent laryngeal nerve is always situated in this area. And if we look at the vagus nerve, it's usually situated between the carotid and the internal jugular. Trachea is an important structure, and it's very clear, and also the esophagus. So those are the one, and this is the dangerous triangle. So if we look at it by ultrasound, so if you look at the carotid artery here in the ultrasound, you see that dark one is ours. The only thing you have to do, and you can see it here as well, you can see it in there. So you just put a color Doppler, and if you put a color Doppler, you don't see the color is taken by this. So this is the vagus nerve. You have to see it before starting your ablation. The grayscale and the color Doppler assessment pre-radiofrequency ablation is important. You have to know where the artery is supplying as well. It's a very important that you have to ablate it at the end, and also to assess the power Doppler for benign thyroid nodule. If you look at that as well, so here the dangerous triangle. So this is the shooting technique that you have to start from more medial and down, and then you go up, and then you start in one by the other until you finish to the top part. This is the hydrodissection. There is a lot of articles written about it, but it can be done. You can go back to the J cancer and you look at it, and you can use it sometime in some of the cases. This is a case with the large thyroid nodule, which is a retrosternal and measuring 5 by 4 centimeter. The largest nodule I have done is 8 by 6 centimeter, but I think it's a very challenge to do big cases all the time. And I think you have to be very careful and be very FNA follicular nodules. And so again, this is doing the FNA. And if you look at this particular, so sometimes we invite our endocrinologists to see what we are doing. And if you're looking at the images here that you are scanning all the thyroid nodule prior to doing any procedure, I usually angle the 22 gauge needle so it will be directed easily for me if I want to push the xylocaine. And usually you direct your very important thing that you have to remember that I think it's like a rule of 20, maybe keep your temperature below 20, and I try to keep it below 15, and you can see here that it's 7 degrees. Here is in 9 degrees when we started. This is the timer. Don't exceed 20 minutes in doing radiofrequency ablation. We finish this case in 10 minutes. So this is how it's done, and you could see the needle. It's going all the way down, and then when you're coming back, you could see the like a storm white, and this is the end of the procedure where this is the area after you finish the entire procedure. So needle is in. This is during the procedure. This is after the procedure. Left thyroid nodule was 3.8, 3.2 centimeter during RFT. 3 months later, you could see that this is a regressed into 2.1, 1.5 centimeter. Also, for follow-up of ultrasound clinic nodule in 2 weeks, this is a patient post-RFAT. In 2 weeks' time, you could see the delineation. You could see that the blood and Doppler is all around the nodule. This is after 12 weeks from the time, and this is the regression after 6 months. This is a female patient with hypercalcemia secondary to hyperparathyroidism. So parathyroid RFA is something easily done. Also, this is another patient as a courtesy from Dr. Mohammed Ashamri, male patient with neck lump, midline. And if you look at the CT scan of this patient, it is in the center, and it's a thyroglossal cyst, and it can be also ablated by radiofrequency. If you look at these images, this is when you do your local anesthesia most of the time. So it's a very important your local anesthesia and cover calcium. Protocol of nerve heat causing a focal cord paralysis. This is how I do it, truly, because over time you learn a lot of things, and this is one of the most important one that you have to look into it. So during the RFA, you have to check the vocal cord motility. And I will show you some images how we can do it. And if the patient reveal a hoarseness during your radiofrequency ablation, I think you have to stop the procedure. It's very important not to continue the procedure because you already initiated a heat induction into the nerve. So you give 4 milligrams of prednisolone or 8 milligrams of dexamethasone. Inject cold. I have injected D5 dextrose cold in the affected site. Usually it recovers in 12 hours to 3 days. I think you need a lot of reassurance to the patient. It's a very important. Keep talking to the patient while you are doing your procedure. and always keep asking them. I keep asking them, how are you? And one of the patients said, how many times are you going to say, how are you to me? So it's very important that you hear the voice. And I always ask the patient at night, when they go home, they will send me a voice message. So I can see if there is any changes post, which did not happen while they are with us. If focal cord does not recover on these few days, it's that recurrent laryngeal injury and continue cortisone plus vitamin B. Very important to have your team to assess the motility. The ENT, the re-educational programs is very important. That they have to evaluate and they have to do a lot of work for them to regain their to recover from the hoarseness. Usually after 6 months, if the injury is definitely no more recurable. I had only one experience over the more than 100 cases we have done, it was just a hoarseness of the voice, and it continued for about 8 weeks and recovered completely. So this is the focal cord. You ask the patient to just do the voice interrupted, and the voice, then you continue imaging the vocal cord motion, as you can see. Outcome. So radiofrequency ablation is a minimally invasive technique that can reduce tissue coagulation necrosis effectively and safely in a human with ultrasound images. The results has been significant reduction within the first 50% within the first 3 months, and about 80% within the first 6 months, and about 96% within the 1 year interval. The follow-up and the additional RFA, we just mentioned this, and radiofrequency ablation should to be effective and safe for treatment also of AFTN, and showed significant improvement of thyroid function and clinical problem in patients with AFTN. I have 2 or 3 patients who they were in treatment prior to coming to the radiofrequency ablation, and luckily after 3 or 4 months they were off treatments. And I think those ones, they need to be more studied to see this is really a success. I think it's more due to the pressure, and I think the endocrinologist can have more explanation to us on this. The complication, hematoma, voice change, esophageal injury. You will see this every once in a while in some of your patients. You have to reassure them. The most important thing, if your patient does not follow your instruction of using ice packs every 1 hour, every 10 minutes, every 1 hour, not directly on the skin for the first day at least. Otherwise, the closer the nodule to the skin, you will get this. And most of the time, it's not from the radiofrequency ablation, it's mostly from the anesthesia or from the sedation. The complication has been done in a lot of big centers and has incidence of 3.3%. And as we can see here, the complications were presented by 62 patients in 21% for surgical excision. I don't think this is an updated list, and I think we need to work more and hard to publish our multi-center data. And I was trying to collect some of the numbers. It's still not an accurate numbers until now because we need to look into it, but still the complication is low. The significant reduction over the 6 months I have seen, one patient in 3 months, it was reduced more than 75%. And it's surprising. And I think we have to study our patient very carefully. This is the take-home message, which is very important. Tricks and tips. The power used depends on the user and range. I think if you start, you have to start from the 20. Don't increase it until you get used to it. You know, with time, you will start from 30 and 40, and depending on the nodule, how it's responding as well from the first. And I think it's very important how you use, and you will use the increment increase every 10 watts. If there is no appearance of hyperechoic ablation zone, as I showed in it, which is like a storm, it's a white storm. On the ultrasound, after 10 seconds, the power is increasing in 10 watts increment. The duration of the ablation should not exceed 20 minutes to prevent patient discomfort. Do not ablate more than necessary to avoid damage to adjacent structure. With experience, you will learn that you don't have to ablate everything, because it's very important not to damage other structure or closed structures. If the nodule is close to the isthmus, use an ice packs on the point of entry of the electrodes. And I use them all the time while I'm coming out of the ablation. If it is a cystic nodule, aspirate as much as possible first and then ablate it. Hypervascular nodule, use higher power to compensate for heat sink effect. With large nodule more than 4 centimeters, do not try to ablate the entire nodule in one session. And I think some of them you can do 2 sessions if it's big. Most important is talking to your patient, them through it very carefully, and explain important how you explain it to all the ablate, follow up by re-ablate in a few months. So keep them for about 12 weeks, about 2-3 months, and then bring them back again, or 4 months. If you can ablate big more than 4 centimeters at one session, 2 needle puncture. That's say upper pool and lower pool areas. It will ease the needle manipulation. I think I have not done that, but it's easy to do it with one needle if you have done it so many times, so it will be easier. Ablate from deep to the shallow area, as we said, the shooting technique, from distal to proximal area. Ablate feeding vessel and embolize it. And with this, I come to the end, and thank you very much.
Thank you very much, Dr. Ahmed, for this very comprehensive, excellent presentations with a lot of practical trick and tips. And really very thank you. I really thank you, Dr. Ahmed, for this nice presentation. And I would like to open the floor for any question. In fact, we have already first question, Dr. Ahmed, here regarding the complex lesion, cystic and solid component. When do you consider ethanol ablation?
We used alcohol ablation a long time ago, and I have not used it for a while, to be frank. But when we use it now, you aspirate, 2 weeks ago, I had a patient who had a cystic component, and I aspirated completely and I ablated, and it doesn't take much of a time from you to do the ablation. And the result is amazing. Alcohol usually causes a lot of pain. And this is really important that you make your patient comfortable. And I think if you have a new tool, which is better than using alcohol, like in the liver, we used to use a lot of alcohol all the time. When radiofrequency ablation came into the view, we don't use much of alcohol, except if there is a small recurrence and there is a small nodule that we needed to ablate. That's sometimes an indicator. I don't use alcohol.
All right, thank you, Dr. Ahmed. Any more questions from the floor, from the audience? Please ask your questions. I think Dr. Ahmed, he has a great experience with more than 100 patients already. While waiting, Dr. Ahmed, for questions, I would like to ask questions myself. After this great experience with 100 patients, do you usually follow up this patient for 1 year or more than 1 year?
So far, we have completed 1 year on a follow-up on those patients. Remember, there are patients who comes from other areas far away from Dammam. I do most of them in Dammam. I have done few cases as well. We follow them up and we ask them to send us at least, if they are, some of them in Tabuk, some of them in Hafr al-Batin, they come and do the procedure and then they leave. So we follow them up to send us an ultrasound images. We follow them up with, I have two of my nurses that they have to communicate with those patients. So they follow them up for the hormonal assay as well. So we will know the results of their hormones and their ultrasound. I usually repeat the ultrasound after 3 months, and some people, they say 6 months. So I follow up the patient the first 2 weeks. I need to see them, mandatory, because I need to see how they are and how they are doing. And I don't place them on anything, actually, except sometime an anti-inflammatory, and I give them just a Benadryl. I don't put them on antibiotics at all. I follow them up after 2 weeks, and then I follow them after 12 weeks, and then after 6 months.
All right. There is one question from Dr. Walid Asad from Jeddah. He is asking about what is the time interval between ablation sessions if you had to do it in 2 sessions, Dr. Ahmed?
There is a preference on this, but I usually leave them for probably about 3 months, because I want to see the results of that ablation, how good it was, because it's very important to know how much you ablated. And sometimes you will be more satisfied if you see it. So I think if you waited 3 to 4 months, it's fair enough. And then you do your second session.
All right, Dr. Ahmed. We have one more question from Dr. Ali Al-Umari, I think so. He's asking about the effect of ablation on the future biopsy for that nodules. Is it the same effect of radioactive iodine, or is the result will show fibrosis tissue at all time?
Well, I think we need to do that sometime. So the effect of the ablation on the future biopsy on the same nodule?
Yes.
The same nodule, most of the time,
so.
they will shrink. Most of the time, they will shrink. And it's a necrosis. It will become more necrotic, for sure. I think it needs more study, but I don't know if the effect of radioactive iodine on it or not. And same for the effect of future surgery as well. Ali, do you mean to remove it? So he's saying,
hello, Dr. Ali.
It can
Dr.
be,
Ali?
if people require surgery, it's always offered to them before they do radiofrequency ablation. And I had few patients. It was proven to be benign, but they refused to do.
He is asking about the percentage of your patients require some sort of sedation compared to doing it completely with
very
local
minimal.
anesthesia.
You evaluate your patient. I do the math. Patient who requires sedation, I take them to one center and another. They are all in the same umbrella of Al Muasa Hospital. But mostly, I would say 80% no sedation. Except you do your good local anesthesia, and I think it will be excellent. You will have no problem, and you have to talk to your patient and reassure them.
Okay, any more questions from Dr. Ahmed? If you allow me, I have one last question for you. Is there
Please.
any size limit? Is there any size limit for the nodules that you would say, I think this is a surgical candidate rather than RFA?
It's a challenge. I usually try to take less than 5 centimeters as much as, but I have this patient who came to me with a big file like this, who's following his nodules for 10 years. And he has done 5 FNAs, and he doesn't want to do surgery. And he came with the size of a nodule, which is 8 by 6 centimeters. insisted that we have to do it. So I had to do CT scan and all that. He has a very long neck, so he's lucky like another people. So that was the only patient that I had to really encourage myself and do it. We did it in one session because it was more prominent to us than it is embedded deeply. So I told him you might require a second session, but we will start and then we will see. He left to Kuwait. I haven't seen him for about 5 to 6 months. He communicated with me and he's telling me his symptoms from pressure and all that is much better. He's in Kuwait, and if he's coming back, I will see him again. I'll let you know. But this is the biggest that I have done, and I don't think you should start with those cases. I have one patient also who wants to do it, and she refused. And she went on, and she came to me with hoarseness of voice. And she said, I want to do it now. And this is also a challenge because this is a controversial that you should not be jumping into it. But we took her together, ENT, laryngoscopy, all that. We assess everything. And then finally we came to do her. We did her. She regained her voice later on. So that was a very good one. I like.
All right, Dr. Ahmed. In fact, I don't want to stop this nice discussion. I promise you just a few seconds ago that it will be my last question, but I do have one more question if you allow me.
I'm enjoying the weather here, you know. Look at, I'm wearing my winter clothes.
MashaAllah,
It's
tabarakallah.
20 degrees here.
MashaAllah, tabarakallah. So, as you know now, Dr. Ahmed, people mainly in Italy as well as South Korea, they are moving toward radiofrequency ablation of malignant lesions. Are we starting doing this practice in the kingdom so far, or at your center at least?
We haven't started, but there are a few cases that they are roaming around us that we need to probably help them as a palliative. And I think that's a good start to start with. But I think if we do not publish our data and understand what the thyroid nodule in this region is, and I think it's different from what other people are talking about. I think the thyroid is a thyroid, but I think we need to understand and study. And I think it needs to involve a group of intervention, endocrinologists, histopathologists, and I appreciate their work all the time. And I think after that, we need to move towards what can be better for our patients.
All right, all right. So any more question from the audience? I think we are done, Dr. Ahmed. Just before to close this nice talk, I would like to invite you, Dr. Ahmed, as a speaker, as well as doing cases with us. Inshallah, in this coming December, we are doing a workshop for radiofrequency ablation of thyroid in our center, King Fahd Specialist Hospital, Dammam. And I would like to invite you to be one of the speakers on that workshop.
It's my pleasure, Dr. Abdullah, and I would like to take this stage as well to thank the Saudi Interventional Radiology Society. I thank you as a moderator and as a very friend and a colleague and a brother. I thank the audience who's been behind there. And I would like also to take the opportunity to thank our hospital because they had the initiative to start this and they had the strength and the executive and the corporate, as well as all the endocrinologists and all the people behind who are the histopathologists to have this successful trip or journey for the radiofrequency ablation.
All right. At the end, thank you very much, Dr. Ahmed, and have a nice night in Abha, and thank you very much for the audience to participate with us in this nice discussion. Thank you very much.
Also, I would like to thank the company which is behind this production, and also the company which are running the radio frequency ablation. All the names there, and I thank them very much for all their supports.
الله يحفظك دكتور أحمد وحفظ الله الجميع ومساكم الله جميعا بالخيرات والمسرات. السلام عليكم ورحمة الله وبركاته.